RNMD is a show about hospital relationships from the perspective of doctors and nurses. You're very smart, and we know that you would never come to a podcast for medical advice. So obviously, call your non-podcasting doctor and nurse team if you need any medical care. Oh, and we should also mention that we don't represent any hospital at all. Ever. Okay, start the thing.
Hello, everybody. Welcome to RNMD, a show about doctors and nurses working together in this mad world of medicine. I'm Daniel, your doctor host.
And I'm Abby, your nurse host.
And today we're going to be talking about physician and nursing roles.
This is our first episode.
Oh, that's true.
And maybe we should explain our relationship to each other as well.
Yeah, we should do that. I forget sometimes.
So we work at the same hospital.
That's right.
And this idea for this podcast came from us just speaking about our experiences at work and realizing that a lot of the misunderstandings or frustrations that we have with our different departments are really simple, basic misunderstandings of each other's jobs or what's expected of us, of our own management or leadership. So that's sort of the concept of this idea.
Yeah, absolutely. There's a lot of misunderstandings I feel that doctors and nurses have with each other. Oftentimes it's just not understanding the other person's perspective in some way.
Sure.
You know?
Yeah.
And it can get frustrating, definitely.
And
right?
then we yell at each other. No, we don't yell at
No, we don't yell at each other. But no, I first noticed her because I was like, this girl's good. She's a good nurse, right? And she was like, this is the best doctor I've ever worked with.
I was impressed by you, actually. I was impressed. You go in the room a lot. You care about your patients. Your assessments are very thorough. You have a nice bedside manner. Yeah, I was pretty impressed.
So I'm a second-year internal medicine resident. What does that mean, right?
Explain it.
A lot of people don't know those things.
That's true,
like
yeah.
These basic...
I didn't before we...
Right?
Yeah, they don't explain that to us
They don't.
in nursing school. So, yeah, go through that quickly.
First of all, what's a resident, right?
Right.
Everyone's like, what's a resident? They don't even know what that is.
What's an intern? Yeah.
What's an intern?
Yeah, go through it.
So I went to medical school for 4 years. I went to medical school in Toledo, Ohio.
You did a bachelor's degree first.
I did a bachelor's degree first. I went to UCLA, which is the Harvard of the West. And then I went to University of Toledo for medical school. It's the best medical school in Northwestern Ohio, undisputed. And then I went to what's called residency. It's after you graduate medical school, you're considered a doctor, but you need to do specialized clinical training in a residency program. So basically, you're like a practicing doctor until you become official. Mm-hmm. And that's I chose internal medicine, which is a general category of medicine that deals with adult health care, essentially, adult care. Mm-hmm. I don't deal with kids. I don't deal with female issues as much, including like pregnant.
Female issues?
I don't deal with female
from the
issues.
1950s?
No, I don't deal with like gynecological or obstetric.
There you go. Okay.
There we go. I needed to correct.
That's a female problem.
You're right. I'm a train of thought over here. I need her to help me verbalize my thoughts. Whatever. I'm being long-winded, but it's part of a 3-year program, and I'm in my second year.
Okay. And then after that?
After that, I can choose to specialize within medicine, and I'm choosing to go into cardiology eventually.
So that's your fellowship.
Fellowship.
And
yes.
how long is a fellowship?
That one's 3 years.
Okay. And then after that, you'd be a cardiologist.
Then I can be a cardiologist, yeah.
I see.
So I'm not there yet. I'm still in my second year. Actually, I'm towards the end of my second year of my residency.
Yes.
Right? What about you? How did you get here?
It's been a long road for me, actually. I actually started as what's called a UMAP, unlicensed medical personnel, which means I had no actual license. But I was working at a group home while I was in college. Then I was able to pass medications and in that setting function similar to a nurse. because group homes have different rules. Then I became a CNA, which I had a certification to work in a nursing home, which I did. Then I became an LPN, a licensed practical nurse, which is a nursing license, but you have more restrictions than an RN. There's a handful of things that you can't do, and you get paid much less. And then I went to school for my associate's degree, RN.
Wow.
Then I went back to school for my bachelor's degree, which I have now. And now I'm in school for my master's to become a nurse practitioner. So I've literally done every level of nursing. I took the long route.
Wow.
Yeah.
I heard school like 20 times on that.
Now I'm working in a Manhattan ICU. I just started working in the ICU. This is new to me. I was doing med surg before that.
That's cool. What's med surg? Can you explain that?
Med surg is kind of a catch-all. It's medical surgical. So it's any patient who is a medical patient, any patient that's a surgical patient, not requiring step-down care, not requiring ICU level care.
Okay.
Yeah. So I was doing hospice care. I was doing post-op, pre-op. I was doing any kind of medical or social admissions. Kind of everybody. Yeah. You sort of do that too.
Yeah.
Yeah.
I'm med surg, right? Yeah.
Yeah. That's not a word you guys
That's not
use.
yeah.
Yeah.
Those are things a lot of like doctor people don't know, those inner like words.
Those
within,
words,
within like the nursing world.
I mean, that's why we need this podcast, because even basic things like that. I mean, I think I referred to you being in medical school.
That's true. She called me a med student.
Yeah. I didn't even know the difference between a med student and an intern.
Yeah, that's a big problem.
So that's the point.
Yeah.
So, okay, so let's get into it.
I am a student, though. I'm a student of life, right?
Okay. Okay, so let's get into it. So, what are your roles? What are the expectations of a physician within the hospital in your...
That's good. I mean, I think a lot of it depends on the situation. I think we're both working in a hospital setting. Mm-hmm. So a lot of what we do is kind of standardized, and it's very much based on teamwork.
Sure, collaboration.
Collaboration is
a
big thing. It's a big thing. So as a resident, I basically work on a team of residents. I am the senior resident of a team, and I have interns that work with me. Mm-hmm. But the head of our team is actually an attending, who is a licensed physician, who has finished residency and is basically the head of the team. He's in charge of what happens ultimately.
He or she.
That's true. That was a little sexist, right?
Right.
Yeah. Well, I just worked with a male attending,
recently.
So it was so that was in my head.
Okay.
But yeah, actually, most of the attendings happen to be female at my hospital. So, what about you? What's the general?
Generally, I mean, I'm doing the direct patient care, and coordination, collaboration, of the patient. My biggest role is that I'm a patient advocate first, which I think some physicians, I've had some pullback when I say that, patient advocate. I think they...
What does that mean? Yeah, what is patient advocate?
Patient advocate is that my number one job is advocating for the patient's rights, and the patient's best interests, and that includes even if the patient is refusing care. Even if I personally believe they should still receive that care, I need to advocate and be their voice within the team, within the collaborating team, for whatever they want, even if I disagree. I'm assessing the patient, I'm reassessing the patient, I'm monitoring the plan. If there's something that is not working or there's a reason why it's not working, it's my job to let you guys know what's going on. Because in general, I think it's fair to say that the physician is not as closely monitoring the patient, right?
That's true to some extent.
Yeah.
As a physician team, our role is to really assess a patient in terms of their healthcare needs. Why are they at the hospital? What do they need? What is the care that they need? It could be their acute treatment plan. Also, their acute treatment plan along with their general treatment plan in regards to their overall health. Right. So a patient might be coming into the hospital for pneumonia, for example, and that will be what we are acutely treating them for. Which antibiotic choice, what labs or which tests should we be ordering and following up on, but also what other diseases do they have? What other conditions do they have? Are they being managed properly? Who are their physicians? Who are their cardiologists or their pulmonologists? What information do we need to gather to ensure that this patient is getting the health care that they need?
Sure.
So I think it's in some ways just healthcare management, making a care plan for this patient.
That's an interesting choice of words because nurses literally do care planning.
Yeah, I think I think a lot of doctors don't really understand what their care planning is as opposed to.
You didn't even know that nurses did care plans or what they were or where they even are.
Yeah, right.
Right in the chart.
Yeah.
Because it's kind of irrelevant to your job.
At our hospital, we don't even read the care plans. But at the other hospitals I've worked at, I would read nursing notes. So I think it's hospital dependent how much involved, like.
Yeah. It definitely depends on your EMR also. I mean, how you chart.
That's true.
Epic charting, I think you can read it. It's easier. Like we work with Prism right now, and it doesn't work as well. You guys are setting the treatments, the medications. We're implementing that, and we're evaluating that care. That's the main. I feel like that's the biggest part of our job. And then we're also doing a lot of the social issues. We're managing emotional support, family dynamics. We're contacting social work. We're trying to get the patient transport back to their facility or their home. Everybody goes through the nurse. Every specialist that comes to see PT, OT, social work, family, everyone comes through the nurse. So we see that patient on every single level of their care.
Absolutely. I think that that's a misconception also. I think like doctors think that, nurses are just passing medication or they're basically drawing blood or something like that. But there's a lot more to what you guys do, I think. And sometimes doctors don't see it because a lot of times we're sitting at our computers and stuff like that.
Yeah, and so that's another misconception that I think the nurses have is that they're just sitting back there doing nothing, staring at a computer. We're running, we're working, we're sweating, we're turning patients, and we're like really in there emotionally with the patient. And then sometimes I think it can seem like you guys are just sitting in the back, staring at a screen, doing nothing. But the reality is you're really diving into labs and planning, and you're involved in social work also.
Oh, yeah. That's actually the bane of my existence, to be honest with you.
Yeah, it's
Every
difficult.
patient, I couldn't believe how much of my job involved social work and basically case managing, non-medical related stuff. I thought I would come out of medical school and be like Dr. House. You know what I mean?
Yeah.
Every patient's like a mystery, and you need to like find out this diagnostic. Maybe he has a brain tumor in his gullet. I don't know, or something. But it's not. I find myself just like, which acute care facility are we going to discharge this patient to?
Right.
Or what physical therapy needs do they need? Or do they have a home health aide? Or what's their family support needs? Are they functionally capable?
See, and this is interesting to me from nursing because before you and I discussed this, I had absolutely no idea you dealt with any of this. I mean, really, to me, it felt like the burden fell completely on the nurse with some of this issue. And then when I spoke to you, it seemed like you guys would deal with it a lot more than I realized. I mean, that's the point of this whole show, I guess, is to show that neither of us are doing all of the work. There's collaboration.
Yeah, that's true.
For a reason.
That's true.
Yeah.
I agree with that.
And I know some of this stuff is a little basic. We're going to dive deeper into this, but since this is the intro, I thought it was important to go over some of the basics, like what's an intern, and, because that's stuff that I actually think a lot of people don't even know. And when I have people, specialists especially, we do a consult, and some of these people who are coming in, I don't know if they're a resident. I don't know if they're a fellow. I don't know if sometimes on night shift, you don't know if somebody is an attending because we don't have a lot of attendings on nights. So it can.
You work at nights only, right?
I only work.
Generally.
Generally, yeah, I work only at nights.
What's that peanut butter in my throat?
Oh, no. before we recorded, Dan thought it would be a great idea to eat a whole spoonful of peanut butter.
Yeah, to soothen my throat.
Soothen?
Soothen.
My friend
out.
Soothen.
Soothen. Yeah, had a jolt of adrenaline, catecholamine surge.
Oh my God.
And I needed my peanut butter.
Okay. All right. Catecholamine.
Yeah, she doesn't know what that means.
I don't. I don't know what that means. You're right.
That's okay. This is an educational podcast.
Is it? It literally says at the beginning, this isn't medical education.
This is medical advice. Anything you hear.
No.
You have any questions, call in.
No.
Do you have a chest pain? Call us. We will give you advice.
No, wrong.
Do not go to the emergency room. We will give you
cut.
medical advice.
We're going to cut.
No, scratch that.
Okay.
No, but also keep that because that was kind of funny. Yeah, so this is our first podcast.
First podcast. Neither of us have ever done this before. Bear with us as the sound quality will definitely get better. Things will get better. But I guess we just wanted to do a first intro just to introduce ourselves, our relationship together.
Yeah.
And that we just, overall, the point is that we think that there's a lot of work to be done. Our departments are very separated, and I think that they've been separated for a reason. Traditionally, the doctors were literally giving orders to the nurses and were overseeing nurses, and I think nursing has made a conscious effort to separate the two, which is a good thing, but I feel like you didn't really dive into yours that much.
Yeah, I think that's true. I think that it's...
So, okay, let me tell you my perception.
Okay.
You guys sit in the back.
Right.
You're eating snacks a lot.
But she's a night nurse, so she's limited.
True. That's true. Yeah. You are chatting. You're typing. I see you guys reading.
At night, we're very much managing the floor. So basically, the patients that were being taken care of during the day, the plan was made, the care plan was put into action. And at night, we're basically managing the patients. If anything comes up, acute things that we need to manage. So it's different at night a little bit.
So also that's actually a good thing to bring up because we have a little bit of a discrepancy right there. You are told that the attending saw this patient, the plan was made. You are sort of treading water at night.
That's true. If you don't know the patients either, that could be like that, especially.
And if something comes up, then you make critical decisions, but otherwise you're just going to keep the plan as is, right?
Yeah, unless there's discrepancies like you said or things change.
Sure.
The patient's condition or status changes, we need to adapt and change the plan accordingly.
Sure.
And there's a direct coordination between the night doctors and the day doctors as well. But it is a clear distinction that the day team is the primary team and the night team is there to basically, like you said, tread water, make sure the patients are maintained overnight.
So that is, first of all, something that I never knew. I was never told that. Yeah. And that is something that's extremely frustrating to the night nursing staff because we're told the opposite. We're told that our job is 24/7 care and that just because it's night doesn't mean you don't make changes, doesn't mean we are certainly not treading water. So we are trying to make changes, trying to improve. And I think a big frustration, at least from me, especially when I was on the floor, was because there's not an attending, the residents are very hesitant to make changes and to the plan until day team gets there. They're usually wanting to say, I'll bring it up with the day team. And for me, someone who is seeing something that could be fixed in that moment, that can be frustrating.
Definitely. No, I would be frustrated by that too. I think that it depends how proactive the night team decides to be.
Yeah.
You know what I mean?
Yeah. And you are actually very proactive, and that's one of the reasons why I always liked working with you. But not everyone is like that.
Not everyone's like that. I think you need to make a judgment call.
Yeah.
You know, sometimes things are meant for the day team, and it needs to be looked at as a team, as a day team.
Yeah.
You know, as opposed to if there's something acute going on at night, you should, or you find any discrepancies at night, you should address it as you see. You know.
And I guess maybe that's something that maybe a nurse like me, some nurses might see that and say, yeah, that could go to the day team. And then I think especially the younger nurses, they're a little more they have a little more energy,
Right.
and we want the plan fixed, and we want it fixed now.
Right,
And
right.
where I think you're right, sometimes it could wait for the day team.
Yeah.
And we get very frustrated, and then you get frustrated with us
Right.
also.
That's true. That's
Yeah.
true. One thing I definitely do want to talk about, kind of off topic, is interns.
Yeah.
Interns is something that
Yeah,
right?
that's going to be a
That's
whole.
gonna be a whole thing, right?
That's
Right?
going to be a whole show.
we gotta make- yeah,
Interns,
for
yeah.
Yeah, but we'll get to that. We'll get to that.
Yeah. I think this was a good jumping off point. We just want to thank everybody for listening. Thank everybody for supporting us.
Yeah.
Email us your questions, your comments, your feedback. Let us know if you have any topics you want us to discuss. I want you guys definitely to write in. We're going to have a way for you guys to write in soon and let us know what's going on in your hospital, because we want to talk about all hospitals, but we just felt like we are so separated, and we want to bridge that a little bit. There's no reason for us to be so separated to where the point where I don't even know what they're doing sometimes, and I think vice versa.
I agree with that. I think it's there's definitely a communication barrier.
Definitely.
That I don't think it's like that at every hospital.
No.
But to some extent, it needs to be addressed.
Yeah.
You know.
Yeah. And our personal relationship has really given us time to discuss these problems and a little window into it. So
Yeah.
I'm excited about this project.
Yeah, me too.
Yeah.
I think that we have a lot to discuss, right, guys?
Yeah. And maybe you won't have to eat peanut butter right before we record.
No, that's my pre-podcast tradition, right?
Yeah.
Peanut butter. By the way, we should mention we do also have an Instagram page, right?
We do have, it's RNMD Podcast. That's our handle on Instagram. I'm also the Nocturnal Nurse. Dan has Instagram.
I don't use it much.
He doesn't use it, so don't go to it yet. We'll we'll update you. But yeah, and we also have a email, rnmdpodcast@gmail.com. You can write in. We're going to eventually be taking topics. If you guys want, if you have a conflict at work with a doctor, or eventually we're going to open it up also to not just doctors and nurses. We want to hear from respiratory therapists. We want to hear from the lab, pharmacy, everyone. If you want to write in to us, tell us some of your conflicts, tell us your point of view, and then we'd also like to get some other points of view. We want to explore the topic
Definitely.
fully. Yeah.
Or leave comments on Instagram. Even.
Yeah. Yeah.
If you like the show, or you didn't like the show, or you have some insight.
Yeah. It's a work in progress right now.
Right,
so if you have feedback, we'd love to hear it, because the point is we want to make this fun, and we want to make it helpful.
That's right.
Right?
Yeah. Yeah.
I think that's going to do it for us today.
I think so too. And thanks for tuning in. Isn't that what you say at the end of the podcast?
Is it tuning in if it's not TV?
Thanks for listening.
Thanks for clicking.
Thanks for clicking in.
Thanks for clicking in, everyone.
Thanks for clicking in. This is the RNMD podcast. And bye-bye.
Bye-bye.
Bye-bye.